Hello, this is Dr. Todd Snyder. Tonight's program is on best practices for zirconia bonding. And I want to thank Bisco for sponsoring today's webinar. I couldn't do all the beautiful dentistry that I get to do without their adhesives. So that being said, let's face it, we all do indirect ceramic restorations on a daily basis. And I don't expect to give you something 100% new and different, but it's definitely going to be unique. And there's definitely some pearls. Now, I understand in an hour's time, there may be a lot of information. You may not be able to write it all down. So I'll tell you ahead of time that you can have a digital handout of every slide that I'm showing you. So don't worry about writing things down. If you hear something important, write that down. All right. So if you're not confident in placing zirconia restorations indirectly, in other words, adhering them to tooth structure, then you're in the right place, because this webinar is going to cover the various steps that are necessary for you to be able to perform bonding to zirconia. Now, for those of you that may not know who I am, I'm a general dentist, same as the rest of you, and I've done a lot of cosmetics in my day, helped create a graduate program, became a fellow in the AACD, and I really enjoy cosmetics and doing large rehabilitations. So with that, I've obviously placed a fair amount of zirconia restorations in cosmetic areas. And, with all of my training over the years and all of the research and hands-on bond strength studies that I've done, there are certain materials that make life easier for us to adhere indirect restorative materials to tooth structure. And being that zirconia is the more complex one for most people, or the more challenging one, is why I was asked to give this program, is to tell you more about how you can do this on a regular basis and feel comfortable and confident doing it. Right? Because a lot of people would tell you you can't bond zirconia, and that's not true. You can. You just have to perform the technique well. So we'll talk about it. All right. So obviously a nice big list of all the accolades and things I've done in my career, but just to let you know who you're listening to if you're not aware of who I am. All right. So you've got a case and you've taken the time to diagnose, how you're going to perform the case. And after diagnosing it, the patient says, yes, you finally get to do the work. So we had to attract patients to be able to convert them to move forward such that we get to do the work. Now, that being said, we all perform dentistry differently. I mean, it's artistry. Each one of us does a different type of skill. Based on what we've learned and, how we like to do things, we all will prep things and do things differently. So I don't expect anyone to duplicate exactly what I do, but we'll talk about the basics behind the adhesives and how you can get better longevity out of your restorations if you perform the same type of steps. Now, you may like to use other brands. I'm telling you how to use certain brands tonight to make, life easy, but there's other ones out there. Okay. And as an evaluator for different manufacturers and different organizations, I get to try everything out there. And so there are things that work better in my hands that you may, like something different in your hands. So with that being said, if you've got a case like this where you've got, some veneers, you've got crowns, you've got implants, and you're trying to, let's say, do zirconia across the board, and you want everything to be adhered well, then you have to have different skills and systems for, cleaning and adjusting the zirconia, for cementation, whether it be light cured or dual cured, right? So you have a lot of different ways in which to manage materials. And so that's what we're going to talk about. Now, the same could be said of these. You say, well, a simple zirconia posterior crown or bridge. Adhesion here also becomes very important. If you have good adhesive skills, these could last a very long time. If your adhesive skills aren't that great, this is where, unfortunately, zirconia gets a bad name, in that we use maybe some, self-etching, do everything all in one dual barrel syringe. And we find that it comes off after a year or 3 years or 5 years. And you say, well, is it, zirconia doesn't bond well. And I would say, no, you're wrong. It was probably handled incorrectly. And unfortunately, the biggest problem in dentistry is not the materials so much as it is the individual using them. And that's not to, poke anyone and say, you're the problem. But honestly, technique is the biggest problem in dentistry, is not having a good technique. But there's no way for us to necessarily test our technique if we put something in, because we're not then pulling on it to see how things are performing. So unless you're in a research environment and testing on extracted teeth, you really don't know how good your adhesive capabilities are. You just know if it falls out, that means it wasn't good. If it didn't fall out, you assume it was a success. But let's face it, we used to put crowns on with cements that obviously were not adhesive, and they'd hold crowns on for 20 plus years. And so what's changed? Well, a lot of what's changed is preparation design and, technique as well as materials. And so you have to be very good at understanding materials and utilizing them properly. And so you must have a very good technique also. But for the same token, ideal preparation design, retention form is very important. So your axial wall angulation becomes critical for success as well. So there's a lot of things that help make you more successful, and all of those combined allow you to have, great success over your career. Now, the ADA, in looking at this particular survey here, they're talking about zirconia restoration. You'll see the number one place that we're all using them as general dentists in the survey is posterior crowns at 98% of us. And then you look at posterior bridges at, 78%, and anterior crowns at 61%. And then it drops down to, veneers way down there at 12% and inlays at 6%. Well, I think most of us can agree that the crazy strength properties that zirconia provides, we don't necessarily use them in tiny little places. We use it for convenience of large crowns or strength for large bridges. Well, nowadays, with the aesthetic appearance of some of the zirconia materials, we can use them for veneers now also. So I think if they redo this study, you might be surprised to see there's a lot more people potentially starting to use zirconia for their veneers, provided they have a good technique with adhesion. All right, so I mentioned preparation design is very important. So before you can begin anything, before you can start, with the different materials and isolation and adhesion and all those fun things we want to do, first thing you have to do is obviously prep the tooth. And so in prepping the tooth, we need to have a good axial wall height, so we want like 4 millimeters or more, ideally. We want an ideal taper of about 5 to 8 degrees on the axial walls. So we have a total taper of, let's say, 10 to 16 degrees. So anything basically between 10 and 20 is considered ideal. Okay. Now, if you don't have great retention or you don't have a really long axial wall, then obviously adding in various types of retentive forms like grooves, rounded box forms, those kind of things can be added to give you more surface area as well as more axial walls. Okay. So when you're prepping the teeth, you're thinking about the final appearance. Like, okay, when I'm placing my final restorative material, how thick does that material need to be? How far do I extend for it to be hidden, let's say, interproximally or under the gum line or at the gum line, or maybe they have a low lip line that doesn't show the gum line. You're thinking about all these different things before you're actually prepping the tooth or while you're prepping the tooth. And so that preparation design determines the final product. And so we typically think about that when we're planning. And based on each office, you may plan at certain times. From there, you're also thinking about color, though. Maybe you took off an old crown, or maybe you're prepping a tooth and you find some discoloration in it, and you're thinking, okay, I'm going to use zirconia for strength, and I'm going to use it maybe for masking this discoloration underneath. Well, for the same token, you could say, well, hey, I've got a perfectly healthy tooth here, and I want to use a zirconia that's more translucent, that allows more light to pass through. So like anything, based on how thick the material is we're utilizing and how much color change we need to have inside the restorative material is going to determine our preparation design. So we're thinking about color as well. Now, if we're doing a traditional chamfer preparation, which is what's considered ideal or optimal for zirconia, we don't have to grind away a bunch of tooth structure to do like a modified shoulder or a butt joint margin. So again, chamfer is wonderful because it makes life quick and easy for us as dentists to take less tooth structure away, helps the patient out because they have, again, more tooth to last the rest of their life. And the ceramist in the laboratory, well, they have reduction that's ideal for them to manufacture as well. So it's a win-win to have one simple system for zirconia. Now, granted, if you're doing inlays or onlays, you're probably going to put a different margin based on, what's present. If it's existing MOD filling, what have you, you may have butt joint margins, or you may extend a little beyond those to create a chamfer margin. Okay? But nonetheless, we're here to talk about adhesion. So if we're doing a chamfer preparation design, things to need to think about, obviously adequate reduction. How much reduction do I need to take off for my zirconia? Am I doing like 0.5 of a millimeter? Am I doing 1.5 millimeters? Well, that's determined by strength properties I need and the color properties I'm trying to create. And so to some extent, that oftentimes has to be a conversation with a laboratory technician if we're doing anterior cosmetics. Now, from there, I mentioned axial wall angulation, about a 5 to 8 degree taper. And I said also an axial wall height of about 4 millimeters or more. Otherwise, we're adding retentive grooves and or box designs. From there, margin design, chamfer margin. So again, these are the basis for creating a good, ideal, let's say, canvas in which to work on. And so if you're not using electric handpieces, I would tell you to get some. I think they're phenomenal. I think it's just, the technology to use these days. Air-driven are kind of old and antiquated. The great thing about electric handpieces, for me at least, is I can run this at 2,000 revolutions per minute, and I can make the burr go either clockwise or counterclockwise just by pushing a button on the console. I don't have to necessarily move the handpiece a different direction. I can keep going the same direction. But the beauty of what that does is running at a low rate of speed with high torque, you can't stall it. I can actually modify tooth structure and or margins at the gum line or below the gum line without damaging gum tissue. Because it's going so slow at high torque, I can remove tooth structure. But because it's going so slow, if I have it rolling against the gum tissue, well, I'm not damaging gum tissue. I have just something rolling on the gums real slowly. Now, if it's rolling, counterclockwise against gum tissue, well, then you may cause some curettage. So you got to be careful which way the burr is rolling. But nonetheless, I can turn the water spray off and refine a perfect margin without having to have, a high speed running with a lot of water at high rates of speed. And so that's one of the beautiful aspects of doing this. Now, the other aspect of electric handpieces that's so great is nowadays, if we're cutting off all these high strength zirconias, you need a handpiece that has high torque that can cut through these. Obviously, air-driven handpieces are a little more challenging to cut through zirconia. All right, so if you got the right tool and you understand preparation design, this was a great study, again, talking about the 10 to 20 degree total convergence shown to be optimal for retention, regardless of what type of cementation process you're doing, whether it be traditional, cements, whether it's new, bioactive cements, whether it be adhesive resins. They're saying that basically 10 to 20 degrees is optimal. Now, if you want to read the research study out of the Journal of Prosthetic Dentistry, there is a hyperlink to it. So that digital hyperlink works in your digital handout that I'll be telling you how to get at the end of the program. So it'll be a PDF with every slide I'm showing you. So if you're working on the tooth, you have to ask yourself certain questions. While you're working on the tooth, you might find that, hey, you know what, this patient is a little more difficult to work on. They can't open wide, or they have a lot of saliva, or their tongue's in the way. When it comes to cementation day, I might not be able to isolate this and use traditional resin adhesion. I might have to use some type of cement that is, water tolerant or water soluble, that it's mixed, maybe like a glass ionomer. It's a powder water kind of mixture. And so you're evaluating that while you're working, because you have to understand that when I come back later on, I need to be able to cement. So if I don't have the ability to potentially work well now, what's it going to be like later? So we're thinking about that also, because isolation becomes critical to your success in using resin adhesion, as we all know. Now, from there, you start saying, okay, zirconia. If I have, let's say a core material or a post I have to mask out, well, then I'm going to need to use an opacious zirconia. Now, opacious could be something thin and opaque, or it could be something thin with maybe some nicer porcelains on top of it. And so you have to also decide how much room do I need to give the technician, the master ceramist, to build something beautiful for me. For the same token, you say, well, they've made it easier nowadays that I don't have to use an opacious sublayer with numerous layers on top of it, as far as like feldspathic porcelain that we're baking or pressing ceramics to. We now have the ability to have multi-layer zirconia that gives us the same kind of gradations of color we would have in a natural tooth. For the same token, I mentioned earlier, having translucent zirconias that allow us to create some incredible veneers nowadays in very thin thicknesses that basically are similar to like pressed ceramics or feldspathics that we've used for years. And amongst translucency, they've come out with 3 different gradations of translucency nowadays that have some incredible realistic appearances. So again, when you're doing zirconia, it's not just this arbitrary, like dogmatic thought of, well, it's 8/10 thickness everywhere I go. It's not. It could be, 4 or 5/10 for a veneer. It could be in 1.25 millimeters for a crown. It could be 1.5 to 2 millimeters for a bridge based on how much tooth is there and how much strength we need. So there's a lot of different things. From there, the curing light you use is important. How ideal is that curing light, as far as its output properties, as far as getting through zirconia. Now, if it's translucent zirconia, you have no problem. But if it's one of the multi-layer or opacious ones, maybe your light's not able to get through very well. And so maybe if you're using a light that hasn't been tested or is an older light, if it doesn't have the ability to provide the proper output of energy, then all the time and effort you went into in placing these restorations, if the resin didn't harden properly, well, that's a problem as well. And that's a failure. Okay. So we're thinking about materials. And so if you think about materials, you can classify zirconia into basically 3 different categories nowadays. You have the 3Y TZP, which is the far left-hand column. And basically what that is, that's your kind of traditional zirconia that's been around a long time. That's the one that's been there for like 20 years. And so it has 100% tetragonal phase and 0% of cubic phase. Now, this is the highest strength properties of any of the zirconias out there, but it has the lowest translucency. So anytime you have highest strength, you usually have more opacity. Okay? And so you think of like a metal, high strength, very low opacity. All right, so then you move into the 4Y TZP, which is newer in the category of zirconia. And so you have 75% tetragonal phase and a 25% cubic phase. And that cubic phase is what's starting to give you some of that translucency. The drawback is as you gain more translucency, you start to lose some of the strength properties. So you can see the mechanical properties now, as far as flexural strength, has dropped from 1200 now to 850. Okay, still incredibly strong, right? But from there you go, okay, well, what about 5Y TZP, which is the last column on the right-hand side? You'll see it's 50% tetragonal and 50% cubic. Now, this has the lowest mechanical properties of the zirconia at 650. It's just close to being half the flexural strength of traditional 3Y, but still substantially stronger than like most of the pressables we use. So it's not that it's weak or bad, but in comparison to other zirconias, it's obviously at the lower end, but it gives you the highest translucency and the prettiest aesthetics, I would say, for doing like thin veneers. So if we look at these, 3Y, 4Y, and 5Y, the different materials that are in these categories, you'll see the far left again, 3Y, products like Bruxzir from Glidewell, which is phenomenal, right? And then you've got like maybe 3M SB's Lava, or I should say Lava Plus. And then you go to the 4Y in the middle, and you can see like Katana, which is the Karari Noritake products that they're my favorite. They have some incredible translucency. And then you move up to like the 5Y, and you've got, again, Glidewell in there with their Bruxzir interiors. You've got Katana Noritake with their Katana UT and UTML. You've got 3M SB and their Lava Aesthetic. So you've got a lot of different manufacturers that now are producing numerous different types based on what you need for aesthetics and strength. So you have to decide based on what you have, which of these that you're going to implement. Okay. Now, from there, Ivoclar has done something pretty unique also, in that instead of just being a solid puck of just 5Y or 3Y, you now have a layered puck that not only has layered as far as colors, but layered as far as the types of zirconia. So you've got 5Y, which is more translucent and, let's say, aesthetically appealing at a strength of 650. That's kind of in this incisal / transition zone to create the enamel appearance. And at the same time, you then have the dentin strength of the 3Y, which gives you like, the 1200 megapascals. So you can think of it kind of like a PFM, or porcelain fused to gold, or porcelain fused to metal restoration, where you have this already built together, having the feldspathic pretty porcelain on the outside and the metal strength internally. But this is all zirconia, but they've taken 2 different types of zirconia and put it together into a puck, which is pretty amazing. Now, as I mentioned, the products that I really enjoy using are the Katana Noritake products. And so you can see they have the different pucks here highlighted, showing anywhere from 550 to 1200 megapascals, depending on strength properties as well as appearance. And so where we have high flexural strengths, but enamel-like translucency in their UTML, they have a flexural strength of 550. And then you jump up into their, STML, which has 750, but still has some really nice translucency, but a little more strength. And then you can go up into the HTML at the 1100 megapascals, which is really high strength and some still really nice aesthetics. Okay. So again, you've got these different layers within them. And by having different layers allows you to create those different effects, but at the same time, having different blocks with different types of translucencies allows you to have that aesthetic opportunity as well. Okay. So on the far left side, you can see where like feldspathic porcelains would typically be at like 80 to 120 megapascals, lithium disilicate typically somewhere around 470 to 500, let's say. And so the zirconia is being around 550 to 1200. So again, zirconia is still the strongest thing we have when you think of a solid ceramic. So you look at the layering inside of these blocks, and you can say, all right, there's an enamel zone typically, then there's transition layers or a transition zone, and then you have a dentin. Okay. And so Ivoclar, as I said, has done something unique. Rather than being one uniform zirconia, they're starting to take different types. So I think you'll see more manufacturers doing this. So hence, in my mind, in another year or two, zirconia is going to take over some of the pressable world because of their strength properties and the crazy aesthetics they're able to achieve. Now, if you think of getting zirconia from the laboratory should have already done this for you, but basically you should have a small micro etcher just in case you have to adjust something or the lab forgot to. Okay. But this is, again, a cheat sheet for you, for your office. Doesn't matter if you got a veneer, inlay, onlay, crown, bridge, whatever. You need to have some kind of micro etcher that you can have 50 micron aluminum oxide particles inside of. And at a pressure of about 40 PSI, for about 20 seconds, you're going to hit the inside of that restoration at about a 60-degree angle at about 2 centimeters off the surface. They've actually calculated all this, which might sound crazy, but they calculate it for a reason, because you can potentially damage zirconia if you go at a higher pressure or different particle size, and so they found the best way to optimally condition the zirconia, since zirconia cannot be etched. The only way you can properly treat it is by treating it with a sandblaster. So hence you should have one, but ideally your lab should be doing this for you. Okay. So hence these slides may be very beneficial to you to have to reference back to. Now from there, if you go, okay, I prepped things correctly, I gave my technician enough room based on the material I'd like to utilize. And so having worked on the patient, I can see that it's going to either be easy to create good isolation or it's going to be very challenging. And so based on that, I may have to do cementation with traditional cements that are, moisture tolerant. Or you may say, hey, I'm just doing anterior and I can isolate well and I can get a light through the zirconia because it's translucent, so I could use light cured. Or you may say, hey, it's going to be too thick. I don't think my light's going to get through it. I need to make sure this is going to cure on its own. If that's the case, then I'm running dual cured resin adhesion. Okay. All right. So let's talk about cements. Obviously, if we have isolation problems, glass ionomers are fabulous because they like moisture. They thrive in a moist environment. Not that it needs to be soaking wet, but obviously you want the tooth to be moist. Okay. And if a little bit of saliva happens to get on it, it's not the end of the world. Okay. So resin modified glass ionomers, we've all used them for many years with our porcelain fused to metal restorations or our solid gold restorations, or maybe you've been using already for zirconia. Resin modified glass ionomers work great. Even Christensen at CRA did a great study on this showing that resin modified glass ionomers, if you have proper retention, work phenomenal with zirconia. Okay. So whether it's Kerr's dual barrel system, whether it's GC's dual barrel system or GC's, capsules that you triturate, all of these work extremely well. Okay. The beauty of glass ionomer is you get that acid-base resistant zone where the dentin is actually stronger from having had a glass ionomer on it, but also you get a unique microadaptation to the zirconia, which along with a little bit of, let's say, expansion of the cement, you get a great adaptation and cementation that we've gotten in porcelain fused to metal restorations. Okay, so it's not true adhesion, but it is great, micromechanical adhesion. Right now, some other types of materials that we could look at that are, again, fast, quick, and easy that, again, are moisture tolerant would be something like the calcium silicate cements. And one in particular would be like the Therasem from Bisco. So it doesn't require, a bonding agent. It doesn't require you to have to do a bunch of things to the tooth and the restoration. It's really easy. Okay, so it's a paste-to-paste system. You can use it for all of your crown, bridge, inlay, onlay, et cetera, when you have good retention. And so it actually has the ability to bond to zirconia, unlike the resin-modified glass ionomers, but also its ability to be bioactive like a glass ionomer makes it kind of ideal in a moist environment that you get the best of both worlds. Okay. And so with the calcium silicate, again, unique benefits that it releases calcium and fluoride to help strengthen the tooth in potential areas that might get, exposed to acid attacks in the future. But for the same token, you could say that when you have, let's say, a margin that's always going to be exposed, if that margin is exposed and you have an acidic environment because of the diet that you have taken in at that point, the ability for this material to be alkaline to fight off the acidity is very beneficial. Now, the other thing is the Bisco's Therasem has MDP inside of it. And so the MDP is the chemical which allows you to get true chemical adhesion to zirconia and or metal and aluminum substrates. So you don't need to have a primer. You can have literally this dual barrel cement does everything for you. Okay, so it's actually been made specifically to be beneficial to the tooth and being beneficial to a good chemical adhesion to the zirconia. At the same time, it's easy to identify on a radiograph as far as its opacity. Okay. So in looking at shear bond strengths to zirconia on this right-hand side diagram, you can see the kind of reddish orange yellow color, that's light cured. And then in a self-cure mode, you'll see is the darker kind of gray black. And so with zirconia, you can see that megapascal strength on the far left-hand side. Therasem, gets to almost 35 as far as in light cured, and is about a 27 or 28 on self-cured. And then when you go down the line, you can see like Panavia SA, you can see Reliex Unisem, which a lot of us have used from 3M. You can see Maxim Elite from Kerr. A lot of these products that we've all used. And so you can see the bond strength of zirconia is quite high compared to many other things that are out there. At the same time, you can see on the left-hand diagram, it has a very high calcium and fluoride release to help, again, strengthen that tooth. So where you may have a simple everyday crown, the crown the tooth could be slightly moist, and you can go ahead and utilize this Therasem to bond something in without having to do a bunch of adhesion, which makes life quick and easy. And, again, you can have some cotton rolls in there to isolate and get in and out very quickly. Its ease to clean up makes it nice as well, such that, we're not spending a lot of time trying to clean things up. Again, speed is important in our business, but at the same time, providing a good quality product to our patients. And so that's why we're talking about these different techniques and materials tonight. So as far as cementing using the Therasem, because that's usually the next question that comes up, I put that in here as well as far as a review if you're going back and looking at the handout. And so the restoration itself obviously is going to have to be tried in. If we're going to try it in, we have to clean the tooth after taking the temporary off. And so if we've cleaned the tooth, we've tried it in, we know everything fits, we can then go in and clean the zirconia, right? And we'll talk about cleaning the zirconia. And then after cleaning it, we can simply place the Therasem inside and place it onto the tooth, wiping away some of the gross excess, leaving a little bit on our margins, and then you can tack cure the margins for a couple seconds, right? You remove a little more excess at that point. You can then go ahead and light cure it for another 20, 30 seconds. If, depending on the type of zirconia you have and the ability of your light, and if you're uncertain of it, well, you can allow it to self-cure as well. Okay. So you can refer back to this diagram, and we'll talk more about how to clean the zirconia coming up. But obviously, it's very easy if you have the right materials, and we'll talk about that. Now, another way to cement is a glass ionomer calcium aluminate blend known as Ceramir from Doxa. It is also a unique bioactive product. It also likes a little bit of moisture in the tooth. It's alkaline, has a pH about 8.5, and in the presence of phosphates in saliva, it can actually create appetite. And so the Ceramir is quite interesting as well. So again, a technique for it. Again, both products are very simple and easy to use as far as cleaning the tooth of any temporary cement or debris that's there. Try in your restoration. If it fits well, you can go ahead and either do one of two things. You can just dry out the saliva that's been contaminated in the zirconia. You don't need to use a primer. You don't need to use an adhesive, right? So instantly you're going, well, that's too good to be true. It's easy. You do have to triturate it. So that means you've got to have some type of triturator. I would recommend 3M, their Rotomix. But nonetheless, you simply syringe the material into the crown or restoration, place it on the tooth, hold it in place for 3 minutes and wipe off the excess. And again, fast and easy. Very similar, you could say, in approach to the Theracem. Doxa has a different type of mechanical interaction with the tooth structure, not using a chemical MDP like Theracem, but also has some really good retentive capabilities. And so again, silane's contraindicated. There's no bonding. There's no etching. And so here I had a crown that I had to remove. And so you can see my preparation here after having removed the existing crown. And in placing a nice restoration, whether it be zirconia or lithium disilicate, I can use this Doxa Ceramir. Again, it makes it nice in a moist environment, potentially to have another cement option. Okay, so we're still talking about cements. For larger cases, I could be using this for a large zirconia bridge. I showed you this preparation design earlier. So again, you can decide on using either one of these types of systems for zirconia when you have good preparation to design with good retention. Now, one particular study was looking at this material, and at their 3-year recall, they recognized there was no loss of retention, no secondary caries, and no marginal discoloration, and no sensitivity. Everything was deemed successful, which is quite interesting because we don't see that often in research. And so in looking at this particular study, you can see they had a test material in the form of a piece of ceramic. You could say it's zirconia, and then you could see the dentin underneath it. And in between, they purposely built in a artificial gap, which you can see here. Okay. Now that artificial gap, which is shown as white on the diagram, when you look over on the right-hand side, the actual real product, you'll notice that white artificial gap is actually a black space. Okay. So you have ceramic on top, you've got the tooth below. And so where you think of using like self-adhesive resin cements, from baseline to 31 days out, obviously that resin never filled in the margin. Okay, so if you didn't cement completely with enough resin to go out to the margin, this is not going to fill in your margin. You have a failure. We'll have micro leakage here. You look at a resin modified glass ionomer, which is what a lot of us are using. You'll notice again, from baseline to 31, nothing changed in that margin if they didn't fill it into completion. Same with the glass ionomer. Now it becomes interesting is products like Theracem from Bisco, which is the calcium silicate down here at the bottom, as well as the calcium aluminate glass ionomer, which is the Doxa Ceramir. Hence, I talked about both of those. Pretty amazing study showing that both of these at baseline, just like anything else, obviously, they didn't have cement in the margin. But at 7 days for the Doxa, you can see it filling in the margin. At 13 days for the Theracem from Bisco, you see it filling in also. At 23 days, you can see the Ceramir has filled things in. At day 30, the day 23, the Theracem has, and day 30, I said that wrong again, didn't I? At day 23, Doxa filled it in, and at day 30, the Theracem had filled it in. Nonetheless, these bioactive cements are phenomenal as far as helping the tooth and adhering to the zirconia and giving you something quick and easy to implement in your business. All right. So if we've got a bioactive cement, gives us a nice benefit where you can see potentially a previous crown had leaked and failed, and we had to put something in there as a protective layer. Well, why not putting a protective layer around the whole inside of it in the form of a cement? At the same time, not having to do all the adhesive components that are so time consuming and so technique challenging is another reason why potentially we should use some of these bioactive cements. All right. So you've got a patient that comes in. This happens to be a younger individual. She's in her early 20s. She's got root canal teeth with some bonding on it that's failing. We're going to do some permanent crowns on her. Obviously, you're going to do your preparation design, get your face bow, take your impression and photographs, all those fun things. Which in doing so, you're thinking about the final product, and you're thinking about the age of this patient. That if I use resin, maybe isolation could be a problem. Or maybe resins, since we know they still can break down over time with MMP activity and potential micro leakage and bacteria. And we know that, potentially a margin can't self-seal and it doesn't fight off bacteria. Well, maybe this is a good place for a cement that does have the ability to contend with the oral environment over many years and protect the tooth at the same time. And so in looking at this case, my choice for a younger individual was like, okay, I want to give her the best possible doubt for the rest of her life. I'm going to use a bioactive cement. Okay. Now, if you go from there, you jump into like, okay, instead of using bioactive cements, let's say I can properly isolate. If I can properly isolate, now I can start using resins and have, some maybe potential higher adhesion based on what type of system, what type of resin adhesive system I'm implementing. But you could also start to implement, let's say, a resin adhesive system, albeit maybe not as high strength properties, but let's say it's convenient to use because it's fast and easy. And so you got products like GSEM's Leak Force, you got Dentsply's Calibra Universal, you got Kerr's Maxim Elite. You have different systems out there that we've all seen and or used where it's something you can literally, without even having to condition the tooth, you can, pretty much clean the zirconia and condition it and just put this inside the zirconia crown and put it down on the tooth and get some decent adhesion. Okay, so it's for that purpose we have them, to make things convenient. Let's see. Someone asked a question, what would be some of the disadvantages in using bioactive cements? Well, they don't have the same level of adhesion as, let's say, some of the resin cements that we're heading towards. So if you don't have good preparation design, or you don't have enough retention, or you have someone that's a heavy grinder, and you might want something that has better, strength properties. So then I would say I would steer clear of those particular materials. But you could also say for certain things like veneers, the bioactive cements aren't meant for that. Okay. If you have certain onlays that, again, just like a veneer, don't have good retentive capabilities, they're not recommended for that also. So they have limitations in that sense. But if you've got full coverage restorations, whether it be crown or bridges, that have good adaptation, or you're doing implants and you're cementing an implant onto, let's say, a custom or stock abutment, and you're worried about peri-implantitis, well, then that's a good place to use them. But you have to have, again, good retentive capabilities. And so resins would be a disadvantage in that place. So that gives you a little insight as to far as why I would choose one or another and some of the disadvantages they might have. You're welcome. Thanks. Again, so technique, I throw that in as a reference slide for when you're looking at these. Obviously, if you're going to use a dual barrel self-etched resin material, you need to obviously clean the restoration after having tried it in, right? And after trying it in and cleaning it, you then have to go ahead and dispense this material inside of it. Now, that's if you're trying to get the best adhesion possible. Now, the manufacturer, this is straight from the manufacturer's, his website. And so it's saying, okay, you can dispense a small amount from both sides simultaneously on a paper towel or gauze to get the first amount out, and then mix and put a drop directly onto the table or directly into the restoration or onto the tooth, and then seat things. They didn't say you had to clean things, right? You didn't have to necessarily clean out the zirconia from contamination. They highly recommend it, but they're not saying you have to. Now, to me, I don't think that's fair, because I think it's important that you take the extra time to clean the zirconia if you're using these resin materials. Now, I get it that they have certain characteristics inside them to make life quick and easy, and they will get some adhesion. But for me, I want to provide the best possible adhesion. And so if I'm going to go to that level, that means I'm going to do everything meticulously to the greatest level of detail that I can do. And so we're leading into that. So recognize here that the technique, this is straight from the manufacturer, is saying you can kind of forgive some things. Me personally, I'd say no. Okay, so you have to decide for yourself, but they made something quick and easy that gives you some bond strength. All right. So if we said we had cementation that we talked about, let's go to light cure for a moment. Okay, so if we have a thin zirconia and or translucent zirconia, and you have a strong enough light that can get through it, you go, okay, I'm going to go ahead and try in my restoration. So I've got to clean the tooth. Okay. Once I've cleaned the tooth, I'm going to use a water-soluble try-in paste to adhere, through the adhesive capabilities of a try-in paste that's not water, such that the material stays in place when I'm evaluating it or letting the patient evaluate it. Okay. From there, it also optically connects my restoration so I can evaluate the color. Okay? Now, if I've done this, I now have to clean off that try-in paste. But if it's water soluble, it comes off very easily with me just rinsing things. Okay? But I would tell you use a water soluble try-in paste because some out there are resin based. Not many, but there's a couple. Make sure it's water soluble. Okay. As far as cleaning the tooth, a lot of different things you can use to clean the tooth. You have basically these little flour pumice, individual dosages. Okay. They're known as preppies from Whip Mix. You have a micro etcher, which I mentioned you need if you're doing zirconia. Just be sure not to hit the gum tissue if you're cleaning the tooth with one of these, because if you do and it bleeds, you've got a problem. Okay, so this one's from Danville. It's known as a micro etcher 2A. My personal favorite comes from Curhave. It's known as the OptiClean. This is really just a plastic shank with what looks like a simple polishing point or polishing cup material. It's kind of like a rubberized rubberized, I guess, like coating on the end that you'd think you could just polish a composite with. And so it's probably not much different, but takes temporary cement off very nicely and cleans the tooth. So this is my favorite because you can't damage the gum tissue unless you try. All right. So if the tooth is cleaned and I've tried in my zirconia, now I have to clean the zirconia if I'm using these resin materials, if I want to get the highest bond strength possible. Okay. Now, excuse me, there's a couple different ones on the market. You have Ivoclean from Ivoclar, which you probably have heard. It's been around for a while. You have Katana Cleaner, which is from Carrare. You have the Zirclean, which is from Bisco. And the job of all three of these, although they're all uniquely different, is their job is to remove the phosphates. They are phosphate scavengers. The Zirclean, it basically is utilizing a potassium hydroxide based system. And so the Zirclean from Bisco is quite nice in that you can allow it to sit inside the restoration, on the internal surfaces for 20 seconds and rinse things off. So wherever you're going to be bonding, you can put this on for 20 seconds and then rinse it off. So quick and easy to implement, comes in a syringe. So you can put it right where you want. The Ivoclean, which has been around a long time, that's sodium hydroxide. Okay. And so again, it's an alkaline suspension of zirconium oxide particles. And because of the concentration gradient, it allows the phosphates to jump off the zirconia and into the solution. Okay. So from there, the third product being the Katana Cleaner. Now, this is an MDP salt. And the MDP salt has a pH of about 4.5. The unique thing about this is it can be used both intraorally and extraorally. So I like this one in the sense if you have to do a zirconia repair, I can do this in the mouth. So again, you have to decide which product you like, but I like this one for that reason. Now, how the MDP salt works, you can see here that basically, if you have a contaminated surface, the hydrophobic group of the MDP salt adheres to the contaminant, right? The MDP salt weakens the surface tension of the contaminant, breaking it up, and allows it to basically be lifted off. And then you can obviously rinse things away, okay? Now, if your zirconia has been cleaned, decontaminated from the phosphates that would basically remove, or I would say not remove, they block your ability to bond. You've now removed those to open up the surfaces that you can bond to. So from here, you now need to add some type of ceramic primer. This is not silanes. Silanes are totally different chemistry. You need to have specifically a ceramic primer. These have typically an MDP inside of them. And so the first one here, the Z Prime Plus from Bisco, this one, enhances the bond strength to zirconia and alumina and metal substrates. Okay. And by utilizing this, it's allowing you to then have your resins adhere to the zirconia. So you need this product to be able to chemically adhere your resin to the tooth structure. Okay. Or sorry, to the zirconia. Now, there are other ones on the market. There are a lot of different ones out there. So Ultradent's got their Peak ZM, Dentsply's got their Zirconia Prime, or so not Dentsply, Denmat. Carrare has their Clearfill Ceramic Primer Plus. GC has their Ceramic Primer 2. All of these have an MDP-based system within them that allows you to adhere. Okay. Now, in implementing these, we'll stick with the Z Prime Plus from Bisco. And so let's talk about how you would implement this. If the restoration is sandblasted by the laboratory and you try it into the mouth and contaminate it, you then need to decontaminate it with the Zirclean from Bisco, if we're staying within one family from one manufacturer. After having applied that for 20 seconds, you then rinse it off. You then have to apply a ceramic primer. In this case, we're talking about the Z Prime Plus. That's the MDP. Once you've done this, you can then fill in your resin into your crown or restoration and seat it to get your adhesion. Okay, we'll talk about the tooth in a moment. Now, if you said, okay, if for some reason the lab didn't sandblast it or you're milling something in the office, well, you could do things a little differently. You could try in the restoration and contaminate it and then sandblast it after the fact and then decontaminate it with the Zirclean or something else from a different manufacturer, and then rinse that out and then apply, again, your ceramic primer of the Z Prime Plus. Okay. Both systems work the same. It's just based on who's doing the sandblasting and when you choose to apply the sandblasting component. Okay. Recognize that you can use these in your practice based on who's doing the sandblasting. Hence, it's in here as a quick reference. All right. In utilizing resins, obviously, if you're using light cured, you need to have very thin translucent ceramic, right? Like thin zirconia or translucent zirconia. And if you don't have that, then you need to be using the dual cure to make sure that it's curing on its own if you can't get a light to it. And hence, if you're doing veneers, light cured is the way you're going to go. But for most of your, indirect zirconia is probably thicker, and you're going to want to use your dual cured resin. Now, in looking at some of the systems that are out there, you can notice here that we've got a couple of different systems for veneering. If you listen to enough of my veneer programs, you'll hear that my number one choice is, the choice 2 from Bisco. But I've obviously used Dentsply's Calibra. I've used the VarioLink Aesthetic from Ivoclar. I've used Kerr's Nexus 3. I've used 3M's product as well. All of these will do the same thing. They're all great products. I have my personal favorite being the Bisco because I get to use the same bonding agent, whether it be a direct restoration or an indirectly fabricated veneer or an indirect crown or zirconia. I can use the same bonding agent. Okay. So for me, that's why I use that system, because someone usually asks. Let's see, a question popped up. Am I using zirconia cleansers pre-try-in? No, there's no reason to use a zirconia cleanser pre-try-in, because what the cleanser is doing is it's stripping the phosphate away. It's scavenging the phosphate off the zirconia after you've tried it in. Okay. Someone asked a question about using something in their aquarium. I would have no idea. All right, next slide. Okay, so if we understand that those are the steps that have to be performed in treating the zirconia, well, we also have to treat the tooth. But let's face it, we've all treated the tooth doing our bonding for many years. Okay? You need an etchant. And so for me, I like using Bisco's Uni Etch. It's a 32% semi-gel phosphoric acid that has benzalkonium chloride. You might ask, well, what's benzalkonium chloride? Well, benzalkonium chloride obviously kills bacteria. Normal phosphoric acid will not kill bacteria. So I want to actually help clean whatever potentially is still on the tooth. And by utilizing this, I've done so. Now, if you say, hey, I want to do like a selective etch just around certain margins and then use a self-etching, let's say, resin on the dentin. Okay, great. They make a thicker material, the Select HV etch, which again is a 35% high viscosity phosphoric acid, again, with benzalkonium chloride. So no matter what type of restoration I'm doing, again, direct or indirect, I have an etchant that allows me to kill bugs while I'm etching the tooth structure. So a lot of different adhesives. I mentioned my favorite was Bisco's All Bond Universal for the reason that I get to use it anywhere without having to have additional activators or additional bottles, and I can use it for both light cured and dual cured. Not all bonding agents are said to be able to do the same. The reason I point this out is because for light curing, you can use these adhesives with anybody's light cured resin. Okay, so for me, as I said, I like Choice 2, my veneer cement from Bisco. The reason I like using that is it's very color stable. It's very easy to implement. It's not too sticky. It's not too thick. And so I like it, but you can use anyone's light cured resin cement with anyone's bonding agent. That doesn't hold true for dual cure. For dual cure resins, they have different formulations from each manufacturer. And so you can run into a problem with it not setting up properly or not adhering properly with the tooth and the bonding agent you're utilizing, and the chemistries being very important when you're doing dual cure. You don't want to mix and match different manufacturers typically. Okay, so trying to keep it simple for you, stay within a manufacturer's product line to know your product works with those manufacturers' dual cured resin adhesives. Okay. All right, so let's review real quick for the light cured version. You can see obviously we're checking the etch from the lab, trying it in, using a water-soluble material, then going back and cleaning or decontaminating, we said with the Zirconia cleansers. Then we're using a Zirconia primer. We're having to isolate now because we have moisture involved potentially, and we're using resins. You then are going to etch or selective etch or self-etch the tooth, utilizing your adhesive, right? Then taking your porcelain bonding resin, whatever that light cured version may be, and then placing on the tooth, curing it, and cleaning things up. Okay. Now, the process really isn't that much different if you say, okay, but what about dual cured? Because a lot of times in zirconia, our light's not going to get through it. Well, surprisingly, it's not that much different. Okay. And so again, you've got many systems out there from Kerr, 3M, and Bisco. Bisco has their dual link universal. Okay. So they are dual barrel systems. Now, the difference being, again, that you can't interchange very well. You know, to keep it simple, just say don't interchange with other manufacturers. Okay? The reason for that, again, is the chemistry doesn't always work together properly. They are uniquely different. So some systems have a dual bottle. Some systems have to add a bottle. You know, so there's different chemistry. So be careful. That's the biggest takeaway I'll give you, is that you can't just take any one of these and expect them to work because of chemistry differences and pH differences between brands. Okay? I will say that Bisco's All Bond Universal is said from the manufacturer to work with all light cured and all dual cured resin cements. Most manufacturers will not have that option. Hence, I'm trying to make it simple and saying, stay within a category from a manufacturer. But if you like the Bisco All Bond Universal the same as I do, you have the luxury, again, of utilizing it with everybody. But most manufacturers can't say that. Okay. All right. So if I'm doing dual cure this time, I mentioned the dual link universal from Bisco. I like it, because I can use it quickly and easily with my existing bonding agent. It has good radiopacity, has a nice film thickness. It's not too thick, so it seats well. If I'm doing an inlay or an onlay or crown, what have you, they've got, a universal shade, an A2, and they also have, a milky white shade if you're doing a lot of cosmetic, anterior restorations. So in looking at it, both in a light cured mode as well as in a self-cured mode, you can see that it has a very high shear bond strength compared to many of the different manufacturers' products that are out there. Okay. So again, this is why I'm using it. I want great strength, but I also want ease of use. So let's look at an example. If I've got a crown like this and I'm not using a bioactive cement and I want to use resin adhesion, so I have great strength properties for potentially long-term biting into foods. Okay, great. Then in that case, I'm going to use, again, water-soluble try-in paste to evaluate the aesthetics. I have to clean the temporary cement that was on there off also. There's a temporary restoration there, so I forgot to mention that. Clean off your temporary cement. I showed you how to do that. Then use your water-soluble try-in paste. Right? After doing that, you clean off the water-soluble try-in paste. You then have to decontaminate your zirconia. We talked about that. You've got 3 different options here in which to decontaminate, to strip the phosphates out. I then had told you, this is redundant, but I had told you that you then need to use a ceramic primer with MDP. Okay, so I mentioned the Z Prime Plus, and many other products from other categories, from GC, Carrari, Denmat, and Ultradent that also are ceramic primers. Having used that, you then can go to the tooth and use your favorite bonding technique, whether that's a total etch, self-etch, or selective etch capability based on the manufacturer's products you're utilizing. Having treated the tooth, you can now take your dual cure resin and load it into your restoration, seating that restoration onto the tooth. You can clean away the excess if you've tack cured it. If you're someone who likes to clean all the excess away, I would say be careful, because sometimes you might pull a little bit out of a margin. So I would typically leave some behind and tack cure it and then strip off the excess after it's hardened. Okay. You can also allow, since it's self-cured, you can allow it to harden on its own and not hit it with a light. Or if you're worried that the light may not penetrate, you can allow it to self-harden, and you get to decide. But because it's dual cured, you can harden the material around the margins, so you're not worried about, let's say, sulcular seepage in a case like this. So if I've got a bunch of excess, I may wipe off 80, 90% of the excess and leave a little bit on my margins and tack that margin with a light for 2 to 3 seconds to make sure nothing else is encroaching inside, and then let the restoration obviously harden to completion on its own. Okay. Now, as I mentioned, in cleaning the zirconia, you can decide who's doing the sandblasting. So I threw this slide back in again, because you have to make sure that it's conditioned properly. If the lab did it or if you're doing it, again, think about that. But the steps are pretty much the same as we were talking about, except we've added in a dual cure resin as compared to a light cured resin. So again, trying to keep this simple for you. In a review slide, you can see here that if we've done our try-in on the far left, right, we've done a try-in with a water-soluble try-in paste. We've cleaned the zirconia with the zirconia cleaner. We then place some type of ceramic primer with MDP. We do our adhesion on the tooth. And based on your system, you may choose to light cure that adhesive into place, or if it's got a thick film thickness, you might not be light curing it. You decide for that part based on the manufacturer you're using. You then are going to put the dual cure resin inside the restoration. We're going to call it a crown. Seat it into place, wipe off the gross excess, leaving a little bit, tack those margins so the margins are sealed. And then once it's hardened to completion, you clean up the excess. So again, very easy. Now, if we're looking at Bisco, you'd say, okay, try-in with a water-soluble try-in paste, clean it with a Zirclean, place the Z Prime Plus, place your All-Bond Universal on the tooth, and you can cure that, and then place your Dual Link Universal in the crown, seat it all together, you're good. Now, if you're someone who utilizes other manufacturers' products, well, the protocol pretty much is still the same. The only difference being their adhesion, you have to follow their manufacturer's recommendations, usually one of those little plastic guides, which is easy to follow. So whether it be Carrari's Panavia V5, which is a great system, the VarioLink aesthetic from Ivoclar is nice. The GSEM Link Force from GC is great, has all the different products in there too. 3M does a nice job as well. You decide which one you want to implement. And so when you look at a case like this, you go, okay, now I can see where I could potentially do like veneers and crowns and implant restorations and utilize maybe a light cured resin for my zirconia veneers. And maybe I've got to use dual cured for maybe the crowns. And maybe I want to use the bioactive cement on the implant. And so you have numerous different ways in which to look at these now. Instead of just thinking I'm going to use the same thing everywhere, you have options, whether it be in a specific case or whether it be across numerous different cases. Okay, so you have options available. Now, that being said, I know this is a lot to take in. I covered it a lot in an hour's time. And I told you at the beginning, you can get a handout. And so every slide I have there for you, as well as I had told you that the review parts where I'd finish off a section and give you a review, it's a nice kind of recipe to go back and review. And so if you want a handout, you can go to dentools.com. It's all automated. And so basically when you go to dentools.com, you'll put in your name and your email, and you get an automated email back to you saying, hey, congratulations, here's the link to this hidden page that has all my handouts. Now, if you don't see it, that means it probably went to your spam or junk folder. So you might look there because it's all automated. Unless you wrote your email wrong, it's coming to you. Okay. Now, that being said, if you want to hear more, if you like kind of how I present things, you're welcome to listen to my weekly podcast, giving a lot of information on how I do business in the dental world. And so there's a link to that also inside your handout. The podcast is known as Delusional, Winning the Weekly War of Dentistry. My training program is known as Legion, and you can go to legion.dentist if you want to learn more about how we do business, our systems, our marketing, and how we do everyday dentistry. Okay. That being said, I think I answered most of the questions as they came through. Let me see if there was a couple more. Oh, there's another one here. All right. Someone asked, do I always anesthetize patients to seek crowns with all these steps involved? Surprisingly, I don't. I would say it's probably, 80+% if they're, full coverage crowns or veneers. But, it's surprising, some patients, the veneers are on enamel, or if they're indentin, they're minimally into dentin and they don't hurt, depending on the age of the patient. So no, I wouldn't say I always anesthetize, but I'd say a fair amount, like more anesthetize than not. Let's see, there's another question here. Let's see. Someone asked, how much would the bond strength increase if Zirconia cleanser is used before using Zirconia? I'm not sure. The Zirconia cleanser is always used. The only purpose of it is to clean out the saliva. So if you're using it before, it's not going to change anything. And if you're using it, let's say after the primer, then you missed out and it's not going to work at all. So there's a definite flow that you have to go through to make sure you've cleaned things properly and primed it properly. Then you finally get to add your resin. Okay. Another question that was here. What type of zirconia and cement would you use for retention of a single-winged bonded bridge? Okay. So instead of doing like a Maryland bridge, we have a Pontic with a single wing. Because it's been proven through research that one wing works actually better over time. Honestly, what I just showed you with the dual link from Bisco works great. But for the same token, Panavia would work great. 3M would work great. Kerr, all of them have a system for adhering to zirconia. I like Bisco because I have one system for everywhere in the mouth. Okay. Now, that being said, the same as I could give you numerous bonding agents, it's been proven also, and I've seen it in hands-on bond strength studies, is I can give you the best possible bonding agent on the planet. But if I give it to 50 doctors in a room, some doctors, they will get like literally 2 megapascals of strength out of it. And you'll have like the majority getting 20 or 30 megapascals. And then you'll have some outliers that get like 40 or 50 megapascals. And you're going, but it's the same bottle. Why is there such a huge range? The range is because most people, A, don't follow protocols, and B, there's no way to test the protocol. So based on how one person scrubbed something in for 10 seconds and someone else scrubbed it in for 20 seconds, or someone else didn't scrub at all, based on tiny little details determines how well something's going to adhere. And unfortunately, you can't test those unless you go and do actual research. And let's face it, most dentists don't do much research. But there are places you can go to actually test that. I know Bisco was doing some for a while. Ultradent was doing some. So there are places you can do bond strength studies. Okay. But I would say stick within one product category. But for me, I have no problem using Bisco for something like that. Okay. All right. Let's see. Oh, there's a couple more questions here. Do you have to use the cleanser and primer if using Theracem? No, that's one of the things. And most of the manufacturers will tell you don't have to. I would highly recommend it. If you're trying to deliver the best to your patient, I would add those extra steps. That's just me personally. Another question. Last one I'll answer here. If you're using Theracem, do you etch and bond the tooth? No, you don't have to. Yeah, so it's a dual barrel self-etching bioactive cement. Okay. Great questions. I appreciate all the interaction. I wish you all the best. You have my email up here as well as my website. Should you have more questions after looking at the handout or other thoughts come up, feel free to write me. Always happy to help. I wish you all the best in your career. I look forward to seeing you back here on Viva at some time in the future. All the best.